Welcome to Progenesis Academy webinar, session number 30. Today's topic, does sperm quality affect fertility outcome? We are fortunate to have two fertility specialists, Dr. Sharara from Virginia Center for Reproductive Medicine and Dr. Rifka from Columbia Fertility Associates. We also have Dr. Marlane Engel, Lab Director at Generations Fertility Center, University of Wisconsin. Thank you so much for joining us.
Pleasure.
Thank you for having us.
Thank you.
Thank you.
Today's topic is about sperm and sperm quality. And I think I'm gonna start my first question. We have some questions coming from patients that we're gonna start addressing as soon as possible. But my first question to you guys is, how important is the quality of sperm when it comes to IVF outcome? Dr. Sharara?
So obviously the male factor is pretty critical. I mean, if we look at the patient that we see, one third are a male factor, one third are a female factor, and the other third is a combination. And we were just talking earlier that what we've been seeing over the past few years has been a gradual increase in the age of the couples that are coming to see us, especially the males that are coming to see us also. We have males that come in and they're on their second family, for example, and it's not unusual for us to see a 55 or a 60 or a 65-year-old husband coming in with a new wife. So, and we're going to continue to see this. So obviously the male factor is quite important, and age is becoming a huge factor in this. And I'm pretty sure we're going to touch about what really happens with the sperm as men age throughout this discussion.
Absolutely. Dr. Rifka, how important is the quality of the sperm when it comes to IVF outcome?
You know, we have to define quality. What is quality? This is the big question that we all grapple with. Is it how the sperm look? Or is it how they function? Is it the DNA in it? So quality is a very big term. Of course, sperms are important. We'll talk about quality later. We have to define it.
Sure.
But as Fady said, I agree with him. On the East Coast here, in the Washington area, we rarely see anybody who is 32 who wants to get pregnant. And the couple are usually elderly couple, and we are dealing with eggs and with sperms that are problematic. And so we would have to define quality. I always tell my patients, sperms look good, but their job is not to look good. Their job is to fertilize. It's like if a man is handsome, therefore he is smart. Well, he can look great, but he is probably a dumb guy. So sperms have a different story. Their function is to fertilize, and we will hope to talk at this session about whether they can fertilize or not.
Thank you so much. Dr. Engel, one of you, you're a lab director, so one of the areas you look at is andrology lab. Can you define quality for us?
I'm not sure I can, because I mean, how many times have we all had that conversation? Is it eggs or is it sperm? And if there was a really clear delineation, then I think we could, I think it would make our lives much easier. As clinicians and lab directors, we could say, if it's this, we know it's bad. If it's that, we know it's good. And the problem is there just aren't, human beings are so heterogeneous. It's really very, very difficult to put those hard lines in the sand. I can remember one patient years ago who got pregnant with 98% anti-sperm antibodies. And they went through 17 IUIs and they refused to do IVF, and they finally got pregnant. And we were, kidding around with them and said, so you're going to go for number 2? And she said, oh, no way. But we never would have predicted that we would get even number 1. And we all have stories like that. I know we do. And we have seen people with low sperm counts that get pregnant, people with great motility, great counts that don't get pregnant. So it's really difficult, I think, to make cutoffs. I mean, we all try, and thank goodness we can do testicular and epididymal sperm retrievals. I think that helps for all those patients who come in with really, really low numbers. But I remember a paper from Israel many years ago when before ICSI, that said, was showing what happens in repeated cycles. And you can see someone come in one cycle with low counts, low motility, no fertilization, and come in the next cycle and have perfectly normal fertilization. And so we all know that there's huge variability in sperm counts, huge variability in motility, probably not as much variability in morphology, but it all makes it very hard to come up with a clear definition of what you as a patient should do. You should go do donor egg. You should go do donor sperm. It's hard.
So I want to add a little bit. For everybody that is watching today, especially the patients who may not know what's normal. So when we do a semen analysis and we get a report, so there's obviously there's a volume, concentration, motility, morphology, and a semen analysis is just a snapshot in time. It tells us about number or shape or motility. It does not correlate with function. There's a new test that's been out for about 3+ years now from a company called Androvia. It's called CAP score or capacitation score that basically I've been using for about 4 years now. And you could have a guy with a perfectly normal semen analysis with a very poor CAP score. And these are the men that have failed multiple IUI cycles and they get pregnant on the first IVF cycle. So if the CAP score is really low, then this is a couple that needs to stop wasting their time with IUIs and move on with IVF at that point and ICSI. But there are a lot of things that affect the sperm. And that's something I'm sure we're going to start talking about. But for example, some men have varicoceles, and those are affect the sperm function, count, motility, possibly morphology. If we have a smoker, or you have somebody who drinks a lot, or on specific medications, or they have systemic diseases like uncontrolled diabetes or high blood pressure. Obesity obviously is a huge factor in the US right now, and we deal with those type of patients. But so when we meet with couples, obviously we need to ask the guys, what do they do? I mean, Dr. Rifka and I work in an area where we're like the second Silicon Valley, where a lot of patients work in IT, and these guys just don't move. I mean, they put their laptops on their laps and they sit all the time. And, testicles are outside the body for a reason, because they don't like heat. And when you put your laptop on and you sit for 12, 14 hours a day, this cannot be good for the sperm.
Sure. Thank you so much. Dr. Rifka, tell us a little bit about your process of evaluating the sperm donor or the male partner when it comes to sperm quality. And can you walk us through the process and how do you evaluate whether that patient is a quote unquote normal for that cycle?
First, I just want to say that sperm counts are like the Dow Jones Industrials. They go up and down and up and down. So you have to do quite a bit of them to establish a profile. And so a multiple sperm counts is very important. The other thing, I think that taking a good history is good. History of cryptorchidism, for example, will give it away. History of inguinal hernias, believe it or not, give it away because this is a higher association with infertility. And as Fady said, there are lifestyles, mentioned alcohol. I add to it marijuana smoking, leisure stuff that are very bad for the sperms. Other than medication, antidepressants, which we have to think of at this time with COVID. A lot of people are on those things. Other than the alcohol intake and the medications too, and the high blood pressure and what Fady has mentioned. But I think too, a good history of frequency of intercourse. Let me tell you what I think too in my practice. The infrequency of intercourse is enemy number one.
Mhm.
And I think that if we look at a stored specimen of 2 weeks, it's going to be a disaster. So talking about the frequency of intercourse with the couple is very important. Nonetheless, I think a lot of time when things look normal and the woman tubes are open, has no endometriosis, uterus is good, ovarian reserve is good, ovulation is great, periods are regular, sometimes you reach male infertility by exclusion. That is, if the woman is optimized and normalized and she doesn't get pregnant, well, it doesn't take a genius to figure out it's the sperms. And from there on, there are a variety of things that we will talk about later on.
So do you think Dr. Rifka, do you think there has been an increase in intercourse with the COVID shutdown because people have more opportunity? They're not going out as much? Do you think it's happening more frequently?
That's very interesting. We have not done that. Sometimes the stress will work against that. And sometimes the medications and the alcohol and the infights and the social friction inside the house. So we haven't deciphered that. But I think that I've seen a lot of patients who have abnormally shaped sperm, low motility, great count. You ask about the frequency of intercourse, here you have it. So I think that there are certain things other than, we'll talk about the medical and the hormonal and the FSH and the LH and the rest. But I think lifestyle, if you go into it, is very important. I would just want to mention something about, as Fady said, the obesity. With our country here having an increased obesity, this is a real problem for both men and women. I mean, today I had a patient who had a BMI of 40, wants to get pregnant. So I had to put all the red flags in front of her to make sure things don't happen. So these lifestyle changes, if we go into it, we can help the patients a lot. The nutrition, I always tell my patients, you know, in Africa, people are dying of hunger and they are reproducing well. So unless it reaches a very bad level, it probably is not a primary factor, although taking some supplements, some people say might help.
Yeah, but to follow up on Dr. Engel, I mean, I ask my patients this, and one of the things, there's definitely some data that has been published already that, you know, just like there's the college 15, the freshman 15, there's the COVID 15 right now. And the amount of people that are drinking is substantially more than before. So, and when I ask my patients, you know, what's going on? Why are you having, you know, 14 drinks a week? And I say, we're at home. There's absolutely nothing else to do. I'm in front of a computer all day long. And the issue is both husband and wife are drinking now. It's not just the husband. So both are drinking. And there's, if anything, there's probably most of the times less intercourse and more divorces that are happening after COVID.
Every day is a happy hour.
Yeah.
Yeah. Well, and especially when you realize that patients probably underreport.
Actually, sometimes, you know, patients underreport alcohol and overreport intercourse.
Yeah.
That's what they do. Yes. Right. So, and I've had women look at the man and it's like, when I ask them, they say, oh, we have, you know, 4 times a week. And the woman looks at him, it's like, with who? So it's, so the men overreport and, you know, they definitely also underreport the alcohol. And both are a huge issue, as, you know, both of you mentioned.
Well, and they're probably also underreporting cigarettes.
Oh, God, yes, always, always.
Any of those things that don't look good.
Right. So
and marijuana too.
Yeah, exactly. As Dr. Rifka said, marijuana is an issue, but I also ask about other things, you know, anybody doing hard drugs, okay? You're stuck at home. It's been, you know, it's been 9 months already and people are just going absolutely bonkers. So you have to ask for these things.
And one of the major stress relievers, you know, going to the gym and working out isn't.
That's gone.
That's gone too. So, yeah.
Very good. Well, my next question is for you, Dr. Engel. Can you walk us through the process of sperm evaluation in the lab so that patients will understand how that would work?
Sure. For patients, we have them. One of the big changes that has occurred for us is we've allowed more patients to collect their specimen at home. We always used to want people to come into the office to do the sperm collection. But now we're allowing them to collect at home. So they can bring a sample in. We do pretty much the basics of what's asked for by the World Health Organization 5th edition. So we're doing a count, a motility, a vitality. We look for round cells. We do a pH. Those are pretty much the big things. There are all kinds of things you can do to look at sperm function, and often we'll move on to secondary things, but not always as the first line. A lot of it depends on how much patients want to pay and how much, what kind of reimbursements available. And because, that ties into the whole COVID conversation, is that patients probably don't have as much disposable income. So it used to be easy to say, let's do additional testing. But one of the big things that our urologist recommends quite frequently is DNA fragmentation. So we send samples out to ReproSource. We are very fortunate, I think, because we have a urologist that's in the clinic 2 days a week, and he sees patients. There's no wait, and they can get in very quickly to see a urologist for things like Varicoceles, and we just shut down again for elective surgery, so that's going to have an impact on the testes and that sort of thing. But he still can do epididymal sperm aspirations in the office. So that's good, because he does cut downs for his testes. So, we're not doing those, but he just does needle aspirations for his epididymal collection. So we do, I think it's a pretty standard semen analysis.
Standard. Okay. Dr. Sharara, you mentioned the CUP score as a way of evaluating sperm sample. Can you tell us what the concepts behind it? How does it work, or what do you measure?
So it's the CAP stands for capacitation. So they really look at the number of capacitated sperm, and patients now can order it. They go on the company's website and they order the test, and they have a kit. They just send it to them. But briefly, there's we stain the sperm, and it's basically a fluorescent microscopy. We prepare the sperm, and then we send it to them, and they look under the microscope, and they count the percent of perfectly shaped sperm that have capacitated. So the sperm, when capacitation occurs, basically the DNA moves, to the sperm head, where basically it just capacitates. And for the sperm to fertilize the egg, it has to capacitate to be able to fertilize the oocyte. And this capacitation usually occurs, obviously, inside the female afterwards. So if the sperm is non-capacitated, they check for something called ganglioside M2, and basically that would be in the equatorial plate for a non-capacitated sperm, and it moves to the sperm head when it's capacitated. So when you count the capacitation score, you look at the percentage of sperm that have capacity, and the normal is more than 27.6% of these. So if the CAP score is below 27.6%, and the lower the CAP score is, the less likely this man is going to fertilize his wife's eggs by intercourse or by IUI. And there's probably 6 or 7 papers already published on this over the past 4 years.
So have these sperm been washed?
Yeah, they're not washed, but they actually put in in media, to basically get them to capacitate, and that they're sent by Federal Express, and they get them within 24 hours. And there's, if you do them on site or you do them within 24 hours, that number doesn't really change.
Okay, well, that's good because you're going to have to do something to get rid of those.
Correct. Yeah, no, yeah, there are steps, but for you in the lab, it adds maybe 10 extra minutes to be able to do this. But if you're very busy, yeah, the man can just go order, he needs he doesn't need a doctor's order anymore. He can just go on the company's website and request a kit, does the test, and then send it out. And it has, I mean, now I cannot function without it. I have seen so many people with perfectly normal semen analysis who fail their CAP score.
So if someone failed the score, what do you do? What the action?
Well, that's an excellent question. So it depends how low it is. If it's 25, 24, 25, I sit down with them and I ask them all the questions I said before. So basically, stop putting your laptop on your lap, go see a urologist, make sure there's no varicocele. If they're doing marijuana, stop. If they do hot tubs, jacuzzis, saunas, they need to stop doing all these things. If they smoke or drink, they need to cut down on those things. If they're overweight, to lose some weight. And I put them on supplements. So I've seen people definitely improve their CAP score. But if the CAP score is really in the teens, there's nothing that's going to make that CAP score get to normal. And most of these at that point, if you look at the history, it's totally this unexplained infertility where the wife is perfectly fine, ovulating on time. They have intercourse 2-3 times a week. They do it right with LH surges. And the typical history I get coming from other clinics having failed multiple IUIs. So that's your biggest flag right there. So you do a CAP score and the CAP score comes back at 15, 16, then they need to move on with IVF. They should stop wasting their time.
Very good.
But I've seen people at 24, 25 become normalized with these changes.
Mm-hmm. Very good. Dr. Rifka, when you have a patient that you suspect that they are, their sperm quality is not that great and you probably have known their lifestyle, what is your recommendation for that kind of patients to recover the quality needed for IVF?
Okay, just, in the old days when I trained at the NIH, I trained with Richard Cherens, who was one of the gurus of male endocrinologists up there. And we used to carry beads to measure testicular volume. And we used to do all kinds of things. But then later on, he joined our practice before he just retired. And he introduced to us the HbA binding assay. And I think that this has proved, and the rationale behind it is that you pass these sperms into a column of hyaluronic acid, and those that stick are the ones who are able to do it. Why hyaluronic acid is the covering of the egg, and the percentage should be 65%. I have found this to be, and he has found this to be a very good tool in 3 things. One, people who have low HbA binding, they should not waste themselves into doing IUIs. Now, as Fady said, our job is not to make the patient emotions go down and her money go down by doing things that don't work. So if these HbA binding, or we have indication the sperm cannot fertilize the egg, she goes immediately to in vitro. And I think that by selecting sperms by HbA, we have found that the rate of blastocysts have increased. And those who could not make blastocysts, this is a good way for them to end up with blastocysts. So I run usually an HbA assay and to guide me either whether the sperms can do it or not. Now let me qualify, when we say a normal female, we have stopped doing laparoscopy on females. And therefore normal should be between parentheses, because that female could have endometriosis, could have adhesions, could have fimbrial phimosis. In the old days, we used to do laparoscopies on everybody. Now I think with the advent of in vitro, they're easier going through in vitro than doing the laparoscopies. So when we say a female is normalized, it is a qualified normalized. A laparoscopy has not been done. And to call a female normal, she would have to have a normal laparoscopy.
Yeah, we do a variant on that when we treat. So we always use pixie dishes that have the hyaluronan bound to the the droplet in the dish, and so we'll pick sperms specifically from that.
Yes.
So that's a variant.
Yes.
Yeah, I want to follow up on the HPA binding assay. Have you seen improvements in the implantation and pregnancy, the outcome, beside the blastulation rates?
We have seen an increase in blastocyst rate. The implantation depends on you, whether you give me a normal genetic embryo or not. So the implantation is not me, is you. So we have been finding now, that's why we are shifting to mostly embryo biopsies freezing, because that we found has boosted our success rate in pregnancy. So to get blastocyst, I need PIXI. To get fertility and pregnancy, I need your chromosomal analysis.
Yeah.
And young women.
Yeah, of course.
Yeah.
Well,
Yeah.
we're gonna get into the euploidy rate that's or aneuploidy that is caused by sperm. We'll get into that in a minute.
Yes.
But following up on the HPA, there are other devices or other technologies that will screen the best sperm. One of them is the Zymote device. Have you guys used that?
You know, they came and detailed it for us. This is the Zymote device. They are here, I think, in Gaithersburg or somewhere, and we are looking into this.
Very good. Dr. Sharara, any experience?
So they came, and you know, for me, I thought it was a bit interesting that a company is selling a device with 0 publications. So, and I asked to see the studies on this. They said, okay, we have an increase in blast rate, increase in euploidy rate, and they did not have a single paper to share with me. That was about a year ago. And
Yeah,
said,
I think that's changed.
yeah, maybe I still haven't seen that paper. And
well,
yeah,
there's quite a bit coming out of Cornell from Dr. Palermo's lab looking at that.
I mean, we'd love to see the papers if you have them, but you know, when they saw me last year, they had absolutely nothing. They only had a single abstract that was presented, I think, at ESHRE, and with no real publications. So for me, I want to see randomized trials. I want to see differences first before I would tell you this is something I'm willing to consider or not.
That's what they don't have a lot of, is prospective, randomized, you know, controlled studies.
And you wonder if they don't have that, why don't they have that?
Well, I think part of the problem is that it's a startup company with it doesn't have hugely deep pockets, so it's not like Serono who can, you know.
Yeah, but they're selling each one for $150, and you just, you know, you're gonna go and tell a patient pay another $150 on top of everything you're selling, because we have this company that doesn't have a single randomized prospective trial showing that that there's a difference. And I personally can't sell that. Yeah,
well, I understand that. The one thing they have shown that there were a couple of abstracts on at ASRM, particularly, oh, I'm sorry, I'm stuck on her last name. It's Alexandra. She works with Palermo. They've been looking at DNA fragmentation rates with and without the Zymote. And one of the things they have been able to show is that DNA fragmentation rates get down below 2%.
Doesn't mean we're going to get more euploid blasts. So if
there is a study out of Miami that did show a slight, small % increase in the number of euploid blasts. They also presented at ASRM.
I think there is a publication from a lab in Miami about the
that's
Zaki Rehan. But I do agree with you. I mean, more studies are definitely needed to evaluate that. I think the more technology we have, there is a chance that we have more tools to select. I think what we are missing right now is you see thousands of sperms and there's no way you can select.
No, the idea makes sense. I published 2 papers back in '94, so a long time ago, before many people were born even, looking at something called true tracks, and the idea was exactly the same as what this zymote is. So it's basically a membrane, and actually the true tracks was using sterilized cervical mucus. So that was the idea, that basically the sperm that can penetrate this would have a higher chance at actually increasing fertilization. But that's back in '94, and the company basically went bankrupt afterwards, and they never had a product. So the biologically, it makes sense that you could pass them through a membrane. The scientist in me wants to see more studies.
Absolutely.
I agree.
We have some questions from patients. Miriam is going to help us get some questions through. Miriam, if you can get some questions from your list.
Sure. Our first question is from Nikki, who's a patient, and she asks, if sperm quality is low, is IVF your only option?
Dr. Sharara?
No, it depends how low is low. So basically, if you have somebody with less than 1 million total sperm count, then chances are they're going to need to move on with IVF. If now we're talking about 12 millions compared to 15 millions, that's normal, and their motility is fine, especially if the CAP score is normal, those actually I would take them to IUI. But if the count is less than 5 millions, it's very, very unlikely that this couple will get pregnant without the use of ART.
Thank you so much. Dr. Rifka?
I usually take the woman's age into consideration. If somebody is 40 and she's coming with a husband with low sperm count, let me tell you, I'm not going to give her 6 months of IUI. I'm going to advise to go to in vitro directly, because there's no time to waste. So a lot of these things have to be mitigated by the age of the wife. If the age of the wife is less than 35, then you can, if the sperm count is more than 5 million or 10, you can do some IUIs. Most of insurance companies actually mandate that you do that before they go into in vitro fertilization. But I think that it's easier and probably better, the in vitro. They get the embryo storage. Because if a man has low sperm count this year, who guarantees that it's not going to be 0 next year? So the embryos that you make now, and you call them normal, will be an added bonus for these people. And I always recommend that the man will freeze some sperms, because ultimately, who knows whether he will have sperms the next year or not.
Yeah, that's an excellent point. And I mean, I do the same thing. I tell patients to have a line, you need 2 points. With just one semen analysis, that's not enough. But if this guy comes in and 2 years ago, he was at 5 million sperms and now he's at 1 million, you know where this guy is heading. So it's definitely trying to have this couple freeze sperm before he becomes azoospermic is important. Obviously, you send that guy and you have a whole workup. You do the blood work and you have them see a urologist. You do chromosomal analysis. I mean, the whole 9 yards. But again, it's how low is low. That's very important from the question.
Very good. Thank you so much.
Let me just say something about the urologists. They're good for varicoceles.
That's it.
Not good for hormones.
Right. We know more about hormones than they do.
So as a reproductive endocrinologist, I think when you diagnose somebody with a varicocele and you want a varicocelectomy, yes, I will send them. Right. But diagnose male infertility, they will confuse the issue more than ever.
Yeah, most of them are not trained as male urologists. They're as infertility urologists.
Yep. Okay. So, sorry, Nabil.
I will say our urologist does the same thing. He wants at least 2 semen analyses.
Very good. So we have a patient that wanted to ask a question live. She is connected to us at the moment. Hello, can you hear me? I think you need to unmute your mic. Hello?
Yes, are you talking to me?
Hi, how are you doing?
Hi, how are you?
Excellent, excellent. Well, we have you online. Do you want to ask a question?
Yes, thank you so much. So I do have a couple of questions. My first question is, how does age affect male fertility, and does the sperm quality decline over time, especially for men over 50?
Thank you so much. Dr. Rifka?
Okay, yes. With age, there are reporting of probably men having a higher incidence of autistic children, higher incidence of autism, higher incidence of schizophrenia, some cartilage chondroplasia, I think there is. So there are things that are associated with some diseases of the offspring associated with men who are older. Now, as far as the semen quality, there is definitely a decrease in the volume as they go older. Minimal. I don't want to say 50. No one has put a real cutoff age. But as a man progresses in age, the semen volume will go low, the motility load, all the parameters will go low, except maybe the concentration will not go low because it is a function of the volume. So all of these parameters will go low. And of course, the sexual function will go low. So yes, there is a gradual decrease, but not total cessation of fertility. And there is an increase in autism and other diseases.
Very good. Dr. Sharara, what's your...
Yes, yeah, absolutely. I mean, there's many papers that have been published on this, and actually the decrease starts being noticed after age 40. And it just worsens with age. And so that was my point earlier about, men coming in with ages above 55 coming in to have children. Remember that, let's say the age at puberty for a guy was, 12, 13, and that sperm the stem cells have been dividing practically non-stop from that time. So the chances at having new DNA mutations, at having issues with imprinting, the genetic and epigenetic causes of the sperm tend up to increase as men age. So that's why, as Dr. Rifka said, there's the increase in autism and schizophrenia, in even congenital anomalies, imprinting disorders. All of these increase as men age. And there's a new paper that just came out last month in Human Reproduction Update, looking at age of the man and spontaneous miscarriages. And once men start getting older than 30, there's a gradual increase in miscarriages, obviously with the highest being in men above 45. In Europe, and this is a paper from Europe, and they don't see as many older men that we see here in the States. So they stopped at ages above 45. But I can guarantee you, if the same study was done in the US and you continue and you look at men above 55, you will see an even substantially higher chance at miscarriages happening with older men.
I think there's also an increase in bipolar.
Yeah, no question. Any psychological disease. Yeah. But schizophrenia is really the biggest one, more than bipolar and other things. But all mental disorders are increased as men age and become fathers at an advanced age.
So Nabil, is there a test yet for that chromosome 15? What is it? 15Q, like something like 13 to 18. Is there a standard assessment, for like carrier screening? Are they developing anything like that for the male?
Those are tests that are customized. So you can always look at regions of chromosome and customize the test. But as far as sperms goes, you have to test the same sperm that you're going to fertilize with, unless if you want to do just a general screen, but you have a population of cells and each cell could be different, not necessarily identical, especially if we are talking about spontaneous mutations. Spontaneous mutation may happen in one sperm cell, but not in the entire population. And I think that's where the challenge is. But I wanted to follow up with you, Dr. Engel, on the blastulation of sperm that are coming from an old patient, let's say 50. Do you see differences between ages and the quality of the embryo, the euploidy rates and blastulation rates?
Oh, well, certainly differences in euploidy rates. I mean, well, we've tied that more to egg age, and I'm not sure. I'm not sure we've looked specifically at euploidy rates with male age, but because I think a lot of the things we're seeing are later onset, so they're not easily, well, like you just explained, they're not quite so easily detectable, and there's not really a carrier screen for men like there is for women.
The reason why I was asking, because we sometimes have same couple that are using a donor egg, and sometimes they have to have a very different age. So you have someone in the 30s or someone in the 50s, and they are fertilizing the same donor, and we do see differences in euploidy.
Yeah, no question. I mean, that's been published. There's this is not new. The older men using donor egg, the older the man is, the higher the chance of having more aneuploidies and more miscarriages. Right. So that even within a euploidy status, there's a higher miscarriage rate at that point.
Yeah. We're gonna talk, see if our patient has another questions. Do you have any other questions for the physicians and for our lab director?
Yes, I do have two more questions.
Okay.
One question is there any way to improve sperm motility and morphology with either supplements or acupuncture or diet or anything like that? And the second question is there any other inventions except for ICSI that can help deal with the low sperm motility and morphology?
Very good. Dr. Sharara?
Well, I'm going to start with the last one first. If the count is really very, very low, then unfortunately there's nothing that works other than ICSI. You have to remember that before ICSI, all these men ended up using donor sperm to have children. So that has ICSI changed the whole. I mean, it's a paradigm shift. And there are men that should have been kicked out of the gene pool who are now fathers. And I don't know if that's a good thing or not, but basically this is where science is at this point. But is there anything else that can be done to improve sperm parameters? The short answer is, once you rule out everything, you have to look at every specific male and look at what the issue is. So if somebody is overweight, you tell them to lose weight. If somebody is smoking, you tell them to stop smoking. Somebody has diabetic, get your diabetes under control. You're hypertensive, get your high blood pressure under control. Your thyroid is off whack, get your thyroid under control. And then we put them on sperm supplements. But as Dr. Rifka said before, I mean, the way we work the guy, like we work the female, I mean, we send them to get blood tests done for all the hormones. I mean, by the time I send a patient to see the urologist, I've done everything except basically do the physical exam on the guy, okay? So all they have to do is, and most of the urologists now don't even examine the males anymore. They just send them to get a scrotal ultrasound. And if it's a moderate or severe varicocele, then they fix it. If it's not, they tell them to go back to us and then do whatever we tell them to do. But lifestyle modification, so talking about diet, that's a very, very important point. And I tell my patients, junk in, junk out. So if you basically, you are at McDonald's every day and then at Chick-fil-A at night, and, you basically eat cereal for breakfast and all the junk food that you consume, what do you expect? What type of sperm you're going to get at the end? Or for that matter, what type of an egg you're going to get also. So I'm a firm believer in a holistic approach to how we do things. So I start with patients by telling them to change their lifestyle modification the first time they meet with me, because I truly believe all of these things affect egg quality and sperm quality.
And I think patients need to realize that this doesn't happen overnight.
Correct.
It takes months.
Absolutely. And so I tell them, please get a head start from today on, because you're already have wasted 2 or 3 years being like this. So for example, soda consumption is a huge thing. Alcohol, I mean, people forget how many calories are in alcohol. And when you're consuming 7 to 14 drinks every week, that's your, basically 5 to 7 pounds every single year that you're tacking on. And when they stop doing these things, they start losing weight, they feel better, they sleep better. I mean, the whole 9 yards. So I start with lifestyle modification from the first day I meet with my couples.
Very good. Thank you so much. Dr. Rifka?
Well, I totally agree. And I will add to that, the recreational drugs like marijuana and other stuff. We should remember that a sperm cycle is 72 days and that things are not instantaneous. So if we are adding an insult to the testicle, we should not expect any result before at least 2 sperm cycles. So this things takes time, and the faster the patient complies, the better. And of course, improving sperm quality too is increasing frequency of intercourse as well. I think that will help a lot. And next would be the blood testing, hormonal evaluation. We have to talk about prolactin, which is one of these bad hormones that can mess up things and induce not only erectile dysfunction, but hypospermatogenesis too.
Right. I mean, we've all discovered these men with prolactinomas that no one has ever tested them before, because high prolactin is going to crash your testosterone, and that's going to make the sperm really bad. And the treatment is incredibly simple. So you don't test for something, you're not going to find it.
I think the other thing to emphasize that you guys probably see a lot is men that are on testosterone supplements.
Yes.
And have really
compromised
their fertility.
Absolutely. So this is something, again, we ask, and I'm sure Dr. Rifka and I have seen these guys come in and they look like bodybuilders. And many of those have had testosterone injections and they're still azoospermic from that. The question is, how long are they going to stay azoospermic? And there are some men who just will not recover their sperm function. So this is very dangerous to take. And unfortunately, you have all these guys that go to gyms, and we've had people who are not physicians prescribe HCG and testosterone to men. And of course, they don't ask them, are you trying to get your wife or your girlfriend pregnant? But they give them these things, and they don't think these are substances that will affect their sperm parameters.
Yeah, that's great to know. Any other questions before we move to the next patient?
No, thank you so much for answering everything.
Thank you. Thank you so much for attending and for your questions. Miriam, can you take another question from another patient?
Sure. Kimberly says that her husband and her have been trying to get pregnant. They did 4 IUIs, and each time her husband's count has been down or the shape of the sperm has been different due to a possible UTI or dehydration. She asks if this could be why they can't conceive.
Okay. Either you, Dr. Sharara, or Dr. Rifka, in any particular order.
So dehydration does not cause bad sperm. Okay. A UTI is a snapshot in time, and if somebody has UTI, the males, which are very rare, if a guy has a UTI, he needs to get a workup done. UTIs just don't happen in men. If they do, we want to make sure there's nothing bad that's happening to that guy at this point. So so neither dehydration nor a UTI will, you treat the UTI, but if that's gone, they should not cause low sperm count. None of these things would.
Dr. Rifka?
I agree. And just to make sure that if the insemination is given with ovarian stimulation or not, if the woman is taking Clomid or recombinant FSH with IUIs 4 cycles, she's not getting pregnant, it's time to move on to in vitro fertilization.
Very good. Thank you so much. Miriam, another question?
What would you recommend to someone with low morphology? Is donor sperm the best option, or is there any ways to improve sperm quality?
I mean, donor sperm should never be an option as long as a guy is producing sperm. Okay, so if he's completely azoospermic and there's no sperm in the testicles, or it's a Sertoli cell only, then there's a mutation whereby this guy cannot produce sperm. Now, there are some men who have what's called congenital absence of the vas, but that's a different story. We can get testicular sperm and they get their wives pregnant. But 1% sperm morphology is not terrible. The terrible if you have men who consistently have 0% morphology, or have what's called necrospermia, where basically all the sperms are dead. But I'm sure Dr. Rifka will confirm, but we've had tons of people with 1% sperm morphology. And Dr. Engel, I mean, she sees this on a daily basis. I mean, we have, probably hundreds of thousands of men with 1% morphology that have become fathers. Some by IUI and some by IVF.
We just have to look longer for that normal looking sperm when we do ICSI.
Yeah, but and remember, we men produce hundreds of millions of sperms normally. We're not going to get 1 million eggs when we're doing an IVF cycle on somebody, okay? So we will always find more eggs than sperm, even when we're doing testicular biopsy cases. So these are, the egg is a much, much more critical thing for us. And again, something that Dr. Rifka mentioned at the early part of the discussion, the biggest detriment that we see, what I call the double whammy to my patients, are older men with basically older women. This is the killer combination at that point. And for trying to find out the cause of aneuploidy or genetic anomaly within these, the vast majority are because of the egg. But obviously, when you have a bad egg and bad sperm, this is really the kiss of death at that point. The chance of having normal embryos is quite low.
You look at testicular sperm and they have a horrible morphology.
Absolutely.
Horrible, but we still get pregnancies from them.
Yeah, because they're, so the analogy I give to my patient for testicular sperm is like a baby learning to drive a car. Okay, it's just not going to do it. And we just need to help that baby be able to fertilize that egg. Once we fertilize the egg, what we see, and I'm sure Dr. Engel, you agree, is there's a slower, the division is slightly slower in some cases of testicular sperm. So they may not be blastocysts by day 5, but they'll be blast by day 6. But and we may get a lower blastulation rate compared to ejaculated sperm. But most of our patients, as long as they have decent eggs, can lead to normal embryos and basically have babies.
We tend to see lower fertilization rates.
True.
Instead of the 75 to 80, we'll be in the 50 to 60 range. But you still, if you start with a young woman who should be coming in with, 15 to 18 eggs, 50% of that still gives you 6 or 7 or 8. And those 50% of those should become nice quality blastocysts. Mm-hmm. So there's still hope. Even if it's poor morphology, I think there's always hope.
Dr. Rifka, what's your perspective on this?
I think the key to this is a aggressive stimulation to get all the eggs that you can. That will solve it, because as Marlene said, this is they will eventually fertilize, lesser fertilization rate. But when I have somebody with low sperms and low parameters, in my mind, I want to drive this ovary to get as many eggs as we can.
And the greatest thing about that point is, there's at least 2 large papers showing that doing an aggressive stimulation is not going to increase the aneuploidy rate. And now with GnRH agonist triggers, we're not as worried as ovarian hyperstimulation as we used to. And there are some new docs that are getting trained or out in practice right now that have never seen a case of hyperstimulation, which is, again, so things the way we practice have changed substantially over the past 5 years than what it used to be before.
Fantastic. Thank you so much. Miriam, can you take another question?
Sure. Our next question is from Samantha, and she asks if DNA fragmentation can still impact embryo's ability to make it to blast.
Dr. Sharara, I'm going to ask you to tell us a little bit about the test itself and how it's done, but I wanted to ask first Dr. Rifka about addressing this question, and then we go to the test specification with you. Dr. Rifka?
This is the question on the blastocyst quality. Is this the...
Miriam, can you repeat that question?
If the fragmentation can impact the embryo's ability to make it to blast.
So DNA fragmentation index.
Okay. In the sperms, the DNA fragmentation or fragmentation of the embryo itself?
Sperm.
What?
The sperm.
Sperm fragmentation.
Okay. Well, I personally think that I don't use DNA fragmentation in our practice. We use the HbA binding assay. And I think that we have started on the DNA fragmentation. I didn't give us a lot, but maybe because we were not doing genetic testing at that time. Now for the past 2 years, I think most of our patients are opting to go for embryo biopsy. So I do not utilize the DNA fragmentation test in our practice. I rely totally on the HbA binding assay and on the blastocyst biopsy with the genetics from Nabil.
Thank you so much. Dr. Sharara, can you define fragmentation, DNA fragmentation as safe first, and then go into the answer?
Right. So the DFI is a test to look at the percentage of, or it's an index at how many sperms have really fragmented. Okay. So there was multiple tests like SCSA and tunnel assay and all these things. Yes. I'm with Dr. Rifka. I mean, I used to do these probably, 10 years ago maybe, and I stopped doing these because I have not seen much improvement, moving forward. And especially with the move towards embryo biopsies and things, I completely abandoned the use of DFI. Some other clinics still do. I just do not do that anymore, relying whether the test that Dr. Rifka uses or the CAP score or putting our patients on supplements and all these things. And, regardless, many of these patients come in and, let's talk about the Zymote test if you want a little bit later about maybe the improve, at least picking the sperms with the least amount of DNA fragmentation. But it's very clear. And that's what I meant by basically the older woman with the older husband. The older husbands have higher DNA fragmentation that has been looked at. So DFI definitely worsens with age. And, when you have sperms that have a higher DFI, you will see a lower chance at making blastocysts at that point. But the literature is a bit split on this. At least the last time I looked at the literature 4 or 5 years ago, some studies showed that it makes a difference, and some studies showed it does not predict whatsoever the blast formation and euploidy rates. But Dr. Engel can fill us in more.
Sure.
Well, I think part of the problem has been that you're doing the DNA fragmentation index testing on a completely
different sample.
Yeah, exactly.
Right. That's the biggest problem with the DFI.
Yep. So I think one of the advantages, if the data that's coming out of Cornell is correct, then, and we can reduce DNA fragmentation down to less than 2%, and you're combining that with ICSI or a PIXI dish or a capacitation assay. I mean, I think there's multiple things that could be put in line that are going to improve outcomes. But if you know that you've got a sample with a relatively low DFI to start with, I think all of these other tests, whether you're talking the CAP or the PIXI, are just going to potentially improve the possibilities, because you've already got a population of sperm that's pretty low in DNA fragmentation. And I think there just haven't been any real good ways to quantify what's going on in the sperm you use when you use it for ICSI.
Yeah.
There was talk before, if somebody has a very high DFI, is go to the testicle and get sperm from the testicles rather than get ejaculated sperm. Some people believe in this. And I would like to see more data on this before I will tell the husband to go get a testicular biopsy, which is extremely painful.
Dr. Rifka, did you want to add anything?
No, I think that I would avoid testicular biopsy at all costs. This is like shooting a butterfly with a cannon. So this is too much. And I think that one has to have their feet on the ground and consider the patient. So I agree with what Fady and Dr. Engel said.
Very good. I think we're now approaching the end of the webinar. It has been 1 hour. I want to just ask you guys, and especially you, Dr. Sharara, what is in the horizon as far as technology when it comes to picking the best sperm possible for a better blood circulation, better outcome?
Yeah, I think, if the data on the Zymote test or something similar really pans out, we need something more than what we're doing now, okay? So in terms of technology, with PGTA, PGTM, the whole 9 yards, we are at a place where we're having pregnancy rates that I will tell you, when I was a fellow, I would never even dreamed of having 50 and 60% pregnancy rates. The first pregnancy in the US took 102 tries before they got the first pregnancy. And now when you get a young patient coming in and you tell them we're going to put a single embryo and we're getting 70% pregnancy rates, these things were science fiction 10 years ago or even 5 years ago. So we cannot change the egg, or at least, I'll take that back. You can a little bit, okay? But that's a different story. But for the sperm, I really think if a test like the Zymote, for example, really pans out, this is a huge step forward. So if we can pick a better sperm to inject inside the egg, we would at least have optimized the sperm part. The problem for Dr. Rifka and I, and for Dr. Engel dealing in the lab, is not the sperm. The vast majority of our issue is with older eggs. So as a friend of mine says, broken eggs. When they're broken, there's not much you can do to really try to put them back together. So unfortunately, one of the worry about, we were talking earlier before about the impact of the COVID crisis and the economic crisis that's going on. And what we're going to see, we did this analysis. We looked back at the 2008 financial crisis. The number of cycles in women above 40 did not drop. It dropped in every single other age category. The biggest drop was in women less than 35. And I will bet you we're going to see the same thing now.
Very good.
It's just a matter of time.
I think the rate of blast formation, the best experiment would be on donor eggs. So you get donor egg, 20 of them, you put them 4-4-4, and you fertilize them with sperms that are treated with things, and you would see the rate of blastulation. I think you have to normalize for the egg factor, and the best way you can do that would be on donor eggs.
Yeah, that's why, again, we're back to the Zymote thing, needing randomized controlled studies, okay, with larger sample size. When you're talking about anecdotal reports, okay, does the test make sense? Yes, but we need to see results. For us, for Dr. Rifka and I to be converts, we have to see enough data to tell us that this definitely helped. So back to your question, Nabil, I think there's not, for the sperm, we're getting close to probably getting to the point of picking the best sperm moving forward. Whether, high-powered, microscopy was touted a couple of years ago as a possible thing, and it hasn't really panned out. We just need a simple test that we can use in the lab without having to buy new instruments to try to pick that best sperm for each egg. But you can get the best sperm that has 2% fragmentation, and you put it in a 43-year-old egg, it's not going to stand a chance.
Absolutely, absolutely. Dr. Engel, did you want to add something to it?
No, I totally agree. And I was laughing at the fact that I threw a party for my lab when we hit 20% pregnancy rate in the 80s.
Yeah.
So whoever thought we would be here today?
20% was phenomenal back then.
We were all very happy. And
yeah.
Now with a 40% would be out of business.
Exactly. Yeah.
Very good. Well, we are approaching the end of the webinar. I would like to give you guys a minute to introduce your practice, and then we will wrap up the webinar. And I'll start with you, Dr. Rifka, and then I'll go with Dr. Sharara after that.
Well, I will wrap up that male infertility is a very difficult thing to pinpoint unless it's flagrant in front of you. The sperm count nearing zero and parameters that are very bad. I still rely on making sure to do multiple sperm counts, excellent history, probe into the patient's life, and make sure too that the woman is normal or normalized before you ascribe this to male infertility.
Yeah, but talk about your practice a little bit.
About my practice, when we are 4 physicians and a nurse practitioner, we're based in Washington, D.C. We have satellite office in Virginia and Maryland, and we've been in practice. I've been in practice since 1978, and I founded Columbia Fertility Associate with Richard Falk, who has retired, and I think things will go forward. We have a Ph.D. in our lab full-time, Sammy Sun, and we have 4 embryologists. We have an andrology lab, and we have a hormone lab. And we see all kinds of stuff like Fady does.
Thank you so much. Thank you. Dr. Sharara.
So I'm the head of a program called Virginia Center for Reproductive Medicine. It's just me, actually, the only doc. I have 2 people in the lab. We're a small boutique practice, and probably 80% of my patients are poor responders. That's what seemed to be coming to my practice. Before COVID, we looked at the mean age of my patients, and it was 38.5, and I think it's probably over 40 right now, easily. So I'm pretty sure throughout the country, most of the docs are seeing older and older patients coming in, and the younger ones just either lost their jobs or can't afford to have children right now, or don't want to have children right now.
Thank you so much. Dr. Engel?
I'm the lab director for a program in San Francisco that last time we calculated our average age, and this was before COVID, was 39.9 years. So we're right up there with you. We have months where we never see anybody under 40. And it's a little scary. So that's a 2-doc practice. We do about 500 cycles. They're busy docs. Another practice in Albuquerque that's fairly small. It's a single doc practice. A practice in North Carolina in Winston-Salem that's they've just gone gangbusters since COVID. They're up to almost 1,000 cycles a month in a 2-doc practice. And then in my current home practice is the University of Wisconsin Generation Fertility Care in Middleton, a suburb of Madison. And we do about 200 cycles a year. It's a small practice, but it's a university practice. So we get a little bit of everything, transgender, ovarian tissue freezing, you name it. We see a little bit of everything.
Nice.
Very good. Well, thank you so much. Thank you for your wonderful presentation, for your answers to our patients, and for your inputs. With this, we're coming to the end of the webinar. Next webinar will be on 3 parents IVF, myth or reality, and then we'll talk about what is out there as far as technology for IVF, for in vitro fertilization. Thank you so much. Have a good evening, and I will see you soon.
Thank you. Bye-bye.
Thank you. Good night, everyone.
Thank you.
Stay safe.
Good night.
Bye-bye.
Good night.